Bringing together voices in child and youth healthcare. This is CAPHC Presents.
CAPHC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, and the McMaster Children's Hospital Foundation. We would also like to thank the following Keystone partners for their ongoing contributions that support all of CAPHC's programs and activities:
Hello, everyone, and welcome to today's episode of CAPHC Presents. My name is Doug Maynard, and I'm the Associate Director at CAPHC, the Canadian Association of Paediatric Health Centres. And today's webinar is titled Interfacility Critical Care Transport, a National Journey Toward Quality Improvement and Standards of Care. Before we start, I've just got a couple of announcements. First, I want to make sure that everyone is aware of the upcoming CAPHC annual conference being held this year in Calgary, Alberta, from October 19th to 21st, so literally just around the corner, but still opportunities to register for that. And it's going to be a great lineup. The theme is Climbing Mountains, Leadership and Resilience in Pediatric Healthcare, and we've got a great lineup of speakers, including hometown hero and country superstar Paul Brandt. And lots of information can be found on the conference site, which is at conference.caphc.org. So hopefully we'll see lots of you there. We do also record the entire session, so if you do have to miss part in the middle or at the end, you can always go back to the recording. The recordings and any other documents, such as PowerPoint slides or anything like that, that are made available to us by our presenters, will be posted on the CAPHC Knowledge Exchange Network at ken.caphc.org. It takes a couple of days to get that information up, and you will receive an automated message from the system with a direct link to that page, although you can always use the search function or anything else on a number of other ways on the Ken to find all that information. The Ken also does provide an opportunity for comments for those of you that have registered an account on the Ken, and anyone is welcome to register an account, so please feel free to do that, and you can then post comments at the bottom of the page if you want to continue the discussion that might be starting here today, or you can also post links to other information that you think might be relevant to the audience that's participating here. All right, so now let's get on to the presentation. As we said, this is about a national journey toward quality improvement and standards of care. And before we get on to introducing our speakers, I just want to let people know that this has been a long journey, and it started way back in 2008 at what I think seemed like a relatively innocuous conference presentation where people expected you to just sit and listen to something, and then all of a sudden it turned out to be much more than that, as the people in the room in 2008 really saw an opportunity to address a real need in children's healthcare by addressing some of the issues and variations in practice and lack of standards that exist around interfacility critical care transport. And from that time in 2008, from that conference, we fast forward a number of years, we established a working group led by Alan DeCon and Kate Mann, and here we are today with a number of documents under our belt and some great work going forward in partnerships with Accreditation Canada. So what we wanted to do before we introduce our presenters was I just wanted to ask how many of you were there at that conference in 2008? And you can just go up and click on a yes or no on the screen there. All right, we'll close that poll, and it looks like not very many people were. Only 4% of the audience were there in person in Edmonton in 2008, and 96% weren't. So that's interesting. All right, well, let's get on to and introduce our speakers. And the first two that I'm going to introduce are the folks who had been roped in many years ago to be the co-chairs of our Interfacility Transport Steering Committee at CAPHC. And the first I'll introduce Kate Mann, who's a registered nurse with over 25 years of leadership and management experience in the healthcare industry, including a national leadership role for professional practice as the president of the Canadian Association of Critical Care Nurses. And Kate had been a nurse at the IWK Health Centre in Halifax. And joining Kate is Dr. Alan DeCon, who is a pediatric intensivist and clinical professor of pediatrics at the University of Alberta and the Stollery Children's Hospital in Edmonton. And he's the medical director of the Pediatric Intensive Care Transport Team at Stollery Children's Hospital. And following Alan and Kate, we're going to be hearing from Stephanie Carpenter. And Stephanie is with Accreditation Canada and is an accreditation product development specialist since 2010, with her most recently her areas of focus including the development of standards for medical transport, client and family-centered care, and emergency departments. So it's my pleasure to hand the virtual podium over to Dr. Alan DeCon to kick off this session. So over to you, Alan.
Thanks very much, Doug. Now I'm just looking for that magical button to push. Okay. All right. So what I'm going to do is as Doug has spoken to, is tell you about a journey that Kate and I and many people have been part of over the last 6 years. It's a journey not yet ended. In fact, this is really a pit stop, and hopefully what it ends up being is this is an opportunity for us to bring the CAPHC family up to speed on what we've been up to for the last 6 years, and to share some exciting news about where we're going to be going over the next couple of years. So just so we're all on the same page, this is what Kate and Stephanie and I thought we'd speak about today. We're going to give you a sense as to how the initiative began, where it started, and basically the path that we followed to ultimately leading to a very exciting and blossoming relationship with Accreditation Canada. And I wish I could say that path had been premeditated and clearly charted out, and there was never a wasted step. But there were times where there was stumbling along the ways. But I think we're all very happy that we are where we are now, and we'll share a little bit of that story. And then at the end, and clearly not least important in many ways, I think what Kate and I would feel is probably most important is to be able to to share with you some ideas about what the future might hold when it comes to knowledge translation in regards, pediatric transport and kind of our national agenda when it comes to standards and how to be able to move forward as a pediatric and high-risk maternal transport family in Canada, and what some of those opportunities might actually look like. Right, Doug. There we are. My apologies. So. Let me just give you a sense as to kind of where we are right now, and what some of the background behind all of this is, and why this is an issue. We've known for many years in newborn medicine, for actually close to 50 years in newborn medicine, that the outcomes of newborns are better, sick newborns are better, if we provide regionalized care. You don't have a neonatal ICU in every little town across the country. We end up having regionalized care and tertiary care centers that can provide excellence in care to critically ill newborns. We've also got that data over the last 20 years in pediatrics. Our dilemma ends up being is that although that specialized care is regionalized, infants and children aren't regionalized, right? So what we need to do, our challenge ends up being that when we're dealing with critically ill or injured neonates, infants, and children, is how we actually get them from the communities that they live in to those tertiary care centers, if there is not one in their community. I think what we do know now as well is that transport can be provided in many ways, and when it comes to getting those patients from their homes to the tertiary care centers, there's an increasing amount of data that actually reaffirms that if we've got access to critical care transport teams, whether that's neonatal teams or pediatric critical care teams, that is definitely, the use of those teams is definitely associated with reduced morbidity and actually reduced mortality as well. The challenge that we end up having is that those teams end up being a limited resource, and we end up having many providers of transport care across the country outside of critical care teams that move critically ill and injured infants and children. So our challenge ends up being is that there are many providers of transport medicine. The second challenge, or part of that, ends up being is that when you look at the amount of pediatric exposure that the average, especially pre-hospital team of paramedics ends up having, it's very limited. And much of this also applies to the to the transport system as well, to the inter-hospital transport system. We have very, very good flight teams across much of the country, but just based upon how many children get sick compared to how many adults get sick, the vast majority of that team experience of those general teams ends up being adult-based, and that's not just technical skills, that's cognitive skills as well. So we end up having many groups of providers in the transport setting with a significant spectrum of experience and abilities. The final point, just to give some context, is that up until this point in time, there have been no Canadian standards that exist to govern the safe and effective interfacility transport of these patients. In fact, the standards that do exist for pediatric and neonatal transport right now, those that do exist come from the United States. And although there are many good aspects to those transport standards, still transport in the United States is not the same as transport in Canada. So there is the risk always that we're trying to push a square peg into a round hole. So clearly at the end of all this, we're left with a system which is, although regulated, is not standardized across the country. Numerous providers of transport care and a very broad skill set and experience set. But at the end of the day, we want to get those infants and children and high-risk moms transported with minimal morbidity and mortality. So this is a slide that you're going to see later on in the presentation, and really it's just here to give all of you a sense as to this is not just a from point A to point Z path that we followed. As you can see on the left of your screen, all of this, and Doug mentioned this, all of this did start at a CAPHC conference in Edmonton in 2008, but there have been many pit stops along the way, and we're going to describe all of these points, as well as the ones that are going to be coming up in the future, which we're very excited about. So in 2008, there was one of the sessions that was scheduled in Edmonton, I should say, was actually to address the transport of infants and children in Canada. And the way that session worked, there were three of us that were actively involved in transport and transport care. Andrew McNabb from BC, Hilary White from Toronto, and myself in Edmonton, that spoke to a room full of CAPHC attendees about what some of the realities were that we face in the transport setting in Canada, and about some of the challenges that we ended up having, and the points that we ended up trying to make, and I think were heard by many of the people in that room were as follows. We ended up, as I alluded to earlier, we ended up recognizing that there were no Canadian standards for the interfacility transport of infants, children, or high risk maternal, and yet there are programs of excellence that exist all across this country that are tertiary care, most of them tertiary care based, although there are some non-tertiary care based transport systems of children that are very, very good as well. So, one of the questions and the challenges put to us was by attendees at that session was, how can we end up sharing the knowledge and experience from those centers with other centers across the country that maybe are at a different point in their growth, that end up many of them facing common challenges that these more experienced centers may have already faced and met and dealt with already. So how could we end up sharing the knowledge and experience that already exists within the country? I think one of the other points that came out when we all shared our stories within that room was that there is no one model of transport care that exists in Canada, and clearly we felt that it is probably impractical and probably not in the best interests of the patients that we transport to have one cookie-cutter approach to this is what a transport team looks like, and this is how patients should be transported. And I think, along with that, there was a recognition that we do need to be flexible. And some of this comes back to earlier comments I've made about we don't have, pediatric and neonatal transport teams in every community across the country. We need to be able to have a flexible model to ensure that either way, whatever team is going to be moving infants and children and high-risk moms, that we can end up ensuring that team does end up having minimal standards. And I think we did recognize also that many of, in fact, I'd probably say all of the teams across the country, both advanced and experienced and well-established teams, as well as those teams that were just trying to start, end up meeting some common challenges. And a lot of those challenges are basically associated with infrastructure that is sometimes patchwork when it comes to how our individual teams and programs work. And they included things such as, not every team ends up having the best kind of equipment or appropriate equipment to transport the kind of patients that we end up doing. So it's not just a matter of taking equipment out of the ICU and putting it into an ambulance. It's also a matter of making sure that it's relevant and appropriate for the kind of patients that we're actually looking after, whether it's neonates or high-risk moms. Some of the other challenges is that timely access to transport carriers. Even those of us that have well-established transport teams in Canada, we don't have much of the infrastructure that exists, or few of us have the infrastructure that exists in other systems, even in the States, where you have teams that have dedicated ground ambulances, dedicated helicopters, dedicated planes for those specific for the use by those specific teams. So that ends up, giving us a challenge or creating a challenge for us when it comes to timely access to vehicles that often that are providing contracted services. And finally, what we all face is the challenge of having and creating and maintaining a transport team, having a sustainable team of people that are well educated, that are experienced, and yet recognizing that part of having a sustainable team recognizes that we need to have there is going to naturally be turnover and change within our team, and how we end up actually allowing for ongoing growth and development of that team, especially when it does end up having new members within it. So these were all challenges that throughout that room in Edmonton we ended up recognizing. So ultimately, this led to CAPHC basically saying, well, listen, there's got to be, this is actually common problems from within the CAPHC family across the country. Let's actually establish a group that can look at this and actually think of some strategies as to how we address this. So in December 2008, there was a committee that was established by CAPHC. And many people from across the country. It literally was, I'd like to say it was at that time was coast to coast. It wasn't quite, but I think now we've come a long way since that time. We are truly now coast to coast to coast. So, but even at that time, there was we felt it was important that there was national representation. That this is transport is a multidisciplinary process. It involves many players, physicians, nurses, paramedics. The exciting thing is that it went beyond just the healthcare professionals, and basically from very early on, we had transport regulators and leaders from the dispatch and coordinating center community within Canada to sit at our table to actually help steer discussion around what what might be the best standards that we should be shooting for. And finally, we recognize that pediatric transport and maternal transport is not just one team, it's multiple teams that we're talking about, and we needed to have content experts from all of these areas, as well as there are transports, as I've alluded to, there are significant players in transport care in this country that are not dedicated to PICU, NICU, or obstetrical and provide care for all of those kinds of patients. So we've actually had, right from the beginning, we've had representation from some of those non-tertiary care teams as well, which we thought was really important. So I think when we ended up meeting with our very early meetings, some of the important points, and I've alluded to some of these already, but just to stress them, we ended up affirming that that academic centers do provide specialized services and levels of care that do make a difference when it comes to how our patients end up doing. The challenge ends up being there isn't equitable access. Somehow we need to get those children and those high-risk moms from smaller hospitals to larger hospitals, and that the kind of care and how the transport process works clearly does have an impact on morbidity and mortality. So basically, that was one of the founding principles of the group. That was important for us to recognize. And we, as I alluded to earlier, the feeling was that yes, there was ideally having a formal transport program and trained escort personnel would have a positive impact on outcome. And where this comes from, still across the country, there are many, even tertiary care institutions where when a call comes through from a referral center about a critically ill kid or neonate, what happens is there's a absolute panicked scramble of trying to pull nurses from a bedside in the ICU or the NICU, sometimes physicians, and calls being put through to try and find a helicopter or a plane or a ground unit to be able to get that ad hoc team out to the referral center. And clearly that kind of approach probably is not the best approach when it comes to actually getting best care out to the patient bedside in a timely fashion. As I alluded to, we did end up saying that geographic locations do differ across the country, different models exist, different agencies are involved, but regardless, we need to have some common principles that underline how we end up coordinating and managing transport of patients. So coming out of all of that, initially the thought was, we said, okay, well maybe what we need to do is actually create some transport guidelines that will help in the development and organization of transport programs. And so, the feeling was initially, maybe guidelines by themselves will be adequate. And I think as we'll talk about as we go on, we kind of ultimately evolved to there's guidelines, but then there's standards that maybe we need to be spending more time on. So ultimately, what we ended up doing is move towards trying to create and talk about implementing standards of care. And it does end up involving, as you can see on the screen there, making sure that we've got timely delivery of transport services, appropriate and effective communication, oversight, and incident reporting. And that all has to be done through the provision of adequate resources to make all of that happen. And I think this still is a challenge for many teams across the country. Those resources, having a budget line, money to actually be able to implement change within or creation of a transport team, an appropriate and supportive administrative structure that can actually allow for the development and maturation of a transport team, leadership, and I'm talking, yes, it's medical, it's management, it's administrative leadership, having a well-defined and planned out process in place for how you're going to train and educate people within your transport programs, having the resources to be able to have the appropriate kind of equipment, And in the ideal world, wouldn't it be wonderful to have our own vehicles and aircraft? But still, that's not a reality that most of us are actually going to face. And finally, it all comes down to also, in order to make sure that we're providing excellence in care, we need to ensure that we have quality assurance that's happening surrounding transport care. And ultimately, we have to be able to investigate to know what the best care is. That involves having appropriate research that starts with a database that can tell us what we're doing in this country right now, what transport looks like for neonates, children, and high-risk moms, so that then we can actually ask the right research questions to then ultimately be able to make those arguments to be able to ask for the appropriate resources to create change. So finally, we ended up in 2009, after some time and thought, the committee ended up putting out a questionnaire across the country to CAPHC members to try and establish what the current standard of practice was for children in neonatal transport. And that ultimately culminated in a teleconference that CAPHC hosted that allowed us to share the results of that. And once again, not surprisingly, we ended up finding from our colleagues across the country much of what we had recognized already, the disparities in the transport system, validating that we do end up having common challenges across the country, the need for national standards, and the importance of having a national, not just a regional, but actually a national focus on transport medicine. And some of the ideas that came from that webinar and back from the audience were questions around maybe some opportunities that we could look at to move transport in the country, pediatric transport in the country forward, were things such as sharing educational and training models, creating certification standards for transport across Canada for infants, children, and high-risk moms, ensuring that there are appropriate safety standards for patients, but as well for teams, that we're actually doing transport in a safe fashion for the healthcare professionals. And as I alluded to already, the importance of actually having a database so that we could actually know where we are and actually investigate how we want to move forward in the future. There was a meeting in spring of 2010 where we ended up taking much of the information, the background information that the CAPHC network had shared with us, and that group of content experts within that national committee then saying, well, how are we going to move forward? Again, that seemed like a very daunting task at the time. And so what we ended up deciding to do is that ultimately it came down to setting standards. And so the way that we decided to try and establish standards was by dividing the group and the chores into two. One of them was going to be looking at establishing what a practitioner profile is for a minimum profile for healthcare professionals that are going to be involved in transporting neonates, children, and high-risk moms. And Kate's going to speak to that in just a minute. And then also we decided it's not just a matter of having the right people, it's a matter of having the right system surrounding transport. So the second group that actually was going to address equipment standards and actually much of the process issues that surround transport, who to call, how are calls managed, response times, who quarterbacks transports, when those transport calls come in and manages and supports the teams in the field, as well as financial issues. And then finally, as a kind of, I hate to say it, it was almost at the 11th hour, we realized that, okay, we've got a lot of neonatal and pediatric experts around the table. We need to make this more than that. It really needs to come back to having a high-risk maternal component to this as well. So at this point, I'm going to hand over to Kate, and then she'll be able to take us through the next stage of the journey.
So the CAPHC Transport Practitioner Profile Working Group, as Alan has given a really good background of how we got to that point. And this group was one of the two groups. So the other group was looking at systems, and this group was looking at the competencies that the practitioners who provide air medical and critical care transport, regardless of vehicle, should be able to do. One of the things that we actually came to grips with, I think, was certainly that the competencies had to be flexible enough to reflect that the composition of the team would vary across the country. So we weren't being prescriptive about whether or not it had to be RN, paramedic, physician. It was about what were the competencies that the team had to be able to perform if they were doing transport of the population that we were talking about. So we certainly started and had interprofessional representatives from across Canada, from the various professions. We had administrators like myself as part of it and others. We had experts around the table who were direct care providers. We had regulators who were part of the system across Canada. So we really began by comparing what was the current status in regions and what were the existing training programs and what competencies already were defined. We landed on what we called the starting document, which was the BC Infant Transport Team competencies. And we, after extensive review and discussion, we said, okay, this is our starting document. We knew that it had a lot of the components that we wanted to begin with, but also we needed to add to it. So the content experts reviewed the list of competencies to determine the relevance for the population, including OBS, so it says maternal, neonatal, and pediatric, and we inserted additional competencies as needed. This resulted in the document, and now I say this resulted in the document. Believe me, this was like almost a 2-year process of many, many teleconferences back and forth as we actually looked at, well, what are we trying to describe here? And so on July 4th, 2012, we came to our final document, and this document is available on Ken. You can see the link there, but if you go to the CAPHC website, it's pretty well there on evident when you go into the site. So as I was mentioning, the competencies profile document is available on Ken. It's 51 pages long, and what it actually describes in a number of different areas is the competencies that are required for the team. We also made sure that, and you'll see in the document, that it is about advanced knowledge that is required. So we're not talking about an entry to practice in terms of the competencies that are required here. However, so each of them are broken out into different categories, and I'd encourage you to go to the Ken website and have a look at that if you've not had a chance. It really is a valuable document, and I think you will find that in the EMS standards that, and probably Stephanie will talk about this, but this competencies profile is referenced in those standards as of January this past year. So it is a competencies profile that is intended almost to be like a bit of a pick list. So if you're only in the business of neonatal transport, then obviously you would look at the competencies surrounding that, and you would be able to put together, these are the kinds of things that our team needs to know. So on our next slide, you will see the different categories. So this is the table of contents, and the categories are divided in a number of different categories that really deal specifically with transporting the competencies that are required at an advanced level for transporting this population. And in the next slide, you'll see that the table of contents also identifies some very specific by systems competencies that are needed. So it would take too much to go through these, but yeah, I really encourage you to go look at that. So we'll move along. So the other part of what we were talking about was the Transport Systems Design Working Group. We knew what we wanted, but we really weren't clear on how to get there. And monthly teleconferences, lots of people from different disciplines on the line, And we were talking about, are we shooting for the gold standard, minimum safety standard, Canadian excellence, or are we being practical? And we looked at establishing a structure for Canadian pediatric transport system design that we wanted to include things that Alan has already mentioned before, such as equipment and communication and expert medical control. So I've already mentioned that the emergency medical services, or EMS standards by Cumentum, already existed. So our steering committee, which had reformed by this time, so after the practitioner profile group completed its work and the systems design had an idea of where we wanted to go, we came together again and as a large group and said, okay, so now we have kind of defined where we want to go, what is out there, and we started to continually come back to what already existed in standards in Canada, and understanding that a significant group in the country was obviously Accreditation Canada. And so we looked at the Cumentum program because many parts of the system were already being accredited by, for instance, these EMS standards as one component. So we turned our eyes to these standards. And at that point in time, we realized that our partner would probably be best served by establishing a partnership with Accreditation Canada. And so we began to have discussions with Accreditation Canada. Next slide. For most of us in the CAPHC family, we're very familiar with the Cumentum program in our organizations. We know that this is what it looks like. So what our group did was we actually looked at these standards and said, okay, let's use these as our starting point. And we went through them, we broke off into groups, we went through them, and we looked at where there might be additions, edits that could possibly be suggested in terms of enhancements to these EMS standards, because they were designed for the ground system. They weren't really designed for other modes of transport. And we talked about everything from air to water to ATVs to every different kind of mode of transport that you could actually talk about. And many of the things that were contained, elements that were contained within these EMS standards, actually applied no matter what the vehicle was. But there were some gaps that we could see as it related to some of the specific things that we felt were important as it related to the population we were talking about, and also some of the challenges faced, particularly, say, in the air environment. What these discussions resulted in for us was we, as the interfacility transport steering group, we came together and we drafted a document that was recommendations for interfacility transport requirements. And in November of just last year, over 30 of us gathered in Ottawa at Accreditation Canada, where we looked at these recommendations for an entire day, going through them to look at where we felt there could be enhancements to the EMS standards, but also recognizing that we were not the experts in standard development, and that partnership is what we needed with Accreditation Canada. So we also learned an awful lot in that one-day meeting as we met there in Ottawa. So when we did meet, we looked at what we wanted to do was to inform Accreditation Canada on what we had been finding over the last several years as it related to the state of interfacility critical care transport for this population. And we were focused on where there were gaps in the system and where there were opportunities for standards development. We wanted to inform CAPHC and its stakeholders on the Accreditation Canada processes and their existing standards and the potential standards that may be appropriate and applicable to this population, because we knew that the EMS standards would not cover all the elements that we felt were important for the work that we have been doing and identifying. So looking at this partnership that we had come together in November for a discussion, and we wanted to explore those opportunities to work with Accreditation Canada to develop a minimum set of national standards for interfacility critical care. And it was with the goal, obviously, to improve the delivery of transport services for the population. And we wanted to explore the potential for any standards that are developed to be applicable to both ground and air. So again, as I mentioned, the EMS standards were developed for ground, and we felt they were very conducive to addressing some of the gaps that would exist in air with some of the enhancements. So that was some of the things that we had discussions about last November with Accreditation Canada on the opportunity there was to build upon what was already strong in the EMS standards, particularly as it relates to system design as well, and enhance it for the uniqueness of some of the other ways that patients were transported in the system. So we love to produce documents. This is another one housed on the CAPHC website, and this is a 68-page document. But if you go to it, you will see a lot of the discussion that happened in the room with the rationale that is made visible as to why some standards needed to be enhanced or where there were gaps and new standards needed to be developed. That is pretty visible in this document, and I would encourage anyone who's thinking about looking at enhancements in your program that you will also see lots of good information in there from that, including there's pictures of our flip charts that we were doing just to think about what it was that we wanted to make appear. So this document is available and really is a nice consolidation of all the previous work and the discussion that happened with our partner, with Accreditation Canada, that day. So at this point in time, I'm going to hand over to Stephanie, who will really talk about the Accreditation Canada process of standards development, and we'll talk about where we're going from here as it relates to that partnership between CAPHC and Accreditation Canada.
Perfect. Thanks very much, Kate, and thanks to everyone in CAPHC for inviting me
Unmuted.
for this webinar. It's really been a fantastic
Muted.
experience to be involved in this partnership along the way. As Kate and Alan have done an excellent job of describing how long of a process this has been, it has really been the last almost a year, or a little over a year, that Accreditation Canada has really been a part of it, and it's been really, really interesting to see just how much work has been done and be pulled into this. So for my part of the presentation today, I'm going to start by providing a little bit of a high-level overview of what exactly Accreditation Canada is and our process of how we go about building new standards or revising existing standards, because the medical transport project that we've been talking about is a kind of a hybrid of both of those processes as well. And then I'll spend some time talking about this actual project and what the vision for it is moving forward. So just to get going, so we are one of the oldest accreditation bodies in the world. We are a not-for-profit organization. We have an international branch as well. We work with both public and private organizations, and we too are accredited, which is always a little bit interesting. There is an International Society for Quality in Healthcare that accredits healthcare accreditation bodies. So we are very familiar with QI processes and having organizations come in and look at what we're doing as well. So that's always a nice tidbit to let people know. When you're looking at a program like ours that is national in scope and crosses, all provinces and territories in this country, and I know I don't have to tell this group just how diverse those services are, and as Alan did a very good job as well of providing some feedback, some overview of how diverse this area of services are, but we look at all types of healthcare across Canada. We also have some very specific markets. The few examples there on the slide are we work with corrections, Canadian Forces, and Aboriginal Health Services. So those are some specific drill down markets. And when we do develop new standards, we are looking at a national in scope, which I think Kate, as being part of our working group, can probably attest to is part of the challenge. in developing products, because it needs to work whether you're in rural BC or urban Ontario, and everywhere in between. And so that's a unique challenge and a unique piece of our program. When we accredit organizations, we are looking at the system and organization level. We are not accrediting programs. We want to look at the whole picture, from the leadership of an organization to every service that they provide. So that is another aspect of the program. When organizations take part in our accreditation program, there are a number of steps that I will outline in a little bit. But the biggest one that probably most staff in an organization see is the on-site survey. And we do that through our pool of peer surveyors. And our surveyors are people who have long-standing experience in healthcare and are experts, and I believe the slide 550 approximately. It does ebb and flow as people retire and we gain new surveyors. But we have a range of 350 to 425 surveys a year across Canada. The stat there on our number of client organizations, a little over 1,000. It's always a little bit misleading, and which is why we have the number of sites and facilities there as well, because as much as one hospital in Ontario is one client organization, so is Alberta Health Services. So just to provide a little bit of perspective, and another example of diversity across the country. The focus of this webinar, and really I think is the focus of a lot of the work we do here at Accreditation Canada, is partnerships. We couldn't do what we do without all the great partnerships that we have. This slide here provides a snapshot of some of the partnerships that we have across the country. And of course the long-standing partnership we've had with CAPHC has been so valuable, and it's been great to be a part of all of the work they've been doing. We've worked with them on a number of projects over the years, from care for pediatric patients in the emergency department to work with some of our medication safety and some of our required organizational practices, and most recently, as Kate was outlining, working with incorporating the reference of their competency profiles into our emergency medical services standards, and now this work with medical transport. So it's really been a bit of a long-standing partnership that we're really happy to have. So moving to our program, one of the biggest pieces, and I think this has been the focus of today and the focus of a lot of organizations that work with us, is it's our standards. They're designed to be standards of excellence. They are national in scope. The idea is that they provide stretch goals for organizations. So we don't want to set standards so high that organizations can't reach them, but these are not baseline standards either. They're standards that organizations will need to reach for. We develop standards, so that I am a standards developer. That is my position here. I can't be an expert in everything, nor am I. So I rely on the guidance of experts in the field. This is when we pull working groups together, and I as I'm sure any of my working group members can attest to, really work them hard to get all of their expertise and make sure they really inform a document. As well, our standards are updated on a regular basis, and when I dive into the emergency medical services standards, you can see a detailed look of how those have developed over the years, because it's really been an ongoing process for that set. This slide here provides an overview of the Cumentum program and all the standards that are within our program. Along the left-hand side, you'll see those are what we would refer to as our core standards that organizations, that they're done at the organizational level, looking at the leadership of an organization and medication, etc. And then the services, it is a little bit of an eye test depending on what you're looking at, what your screen looks like, but the services provides a list of all the different types of services that we have specific standards for within an organization. Our next slide is our quality dimensions. These are the dimensions that every element in our program are designed around. And really what Cumentum is designed to do is provide a quality framework for organizations. So our program allows organizations to work through a quality improvement journey to really improve their services and evaluate their own services, as well as we provide that external evaluation piece. Just taking a look at this slide, I want to highlight a couple of the things that are really useful to organizations. First, our accreditation primer. That is an actual program here at Accreditation Canada that is for new organizations. So organizations that have not done accreditation before, they're not part of the Cumentum program, and they're probably newer to quality improvement frameworks. And this is actually the case for a lot of emergency medical services organizations across the country. They're one of our newer markets that use that primer program. And what primer is it has a lot of the core elements of the program. It mirrors the content that is in Cumentum, but it's kind of maybe just brought a step back. So organizations have all the same, they have access to the tools, and they have all of the same kind of advantages, but they're just, it's on a slightly scaled back level, and the award is only for 2 years instead of 4 years, which is our Cumentum cycle. And it just allows organizations to have a step in the right direction instead of jumping right into the deep end. Then my next slide here is a shot of the self-assessment. So this is how organizations actually work with the standards. So Kate showed a great slide of the emergency medical services standards in that standards document. This is what people who work in client organizations see when they start working with the standards. And actually use this self-assessment tool to rate their own internally. This is a tool only for organizations. We don't see it. Surveyors don't see it. It is a tool for organizations to work with their own teams and their own data and make improvements as they go, which is really the kind of the core and the value of embarking in accreditation. It allows organizations to set goals for themselves. What areas are important to that organization? What's important to their stakeholders? What's important province to province? We all know that there are different provincial mandates across this country. So the program is designed flexible in a way that it allows organizations to really drill down on what's important to them and work through those quality improvement initiatives. And the last point on this slide, which is maybe a little disjointed here, is that, and it's a larger initiative that's been going on at Accreditation Canada over the last few years, is the focus of client and family-centered care. And it really belongs in kind of all services. And the program is designed to follow the patient journey through an organization, and it really enables organizations to kind of focus on that client perspective and how their clients might see their services, which is obviously very valuable when you're looking at services like medical transport, is really taking that client perspective into consideration. So next I'm going to move into a little bit of our standards development process. And like I mentioned earlier, it looks a little different whether we have new products or we're revising an old product, or I guess a current product, not an old product. When we make the decision to develop new products, it's usually we're asking if there's a gap in what we currently have available.
Unmuted.
And then we really want to take a look at what are the key areas of quality and safety that need to be addressed that aren't being addressed by what exists in the Cumentum program. When we take a look at revisions, we do have an ongoing revision cycle, and it's not set in stone. It's not 5 years for every standard or something like that. It really depends on what's going on in that area of service. So, are there a lot of changes going on across the country? Have there been new clinical practice guidelines developed? What are we hearing from our clients? Is something not fitting right with them? Are there a lot of changes in risks or how services are delivered? So we really that really is a bit of an ongoing process, and it's a really good example of what happened with this project, to be honest, and it is a little bit of both of those things. So when we decide that we're going to start a new product or even revise a new product, we work through a process of having an intensive literature review and doing background research. We form an advisory committee or a standards working group to help develop draft standards, and these are the experts that I was speaking to, and then we evaluate that product before it's released into the Cumentum program. So as part of a literature review, this slide just covers some of the things that we'll want to look at, and this looks different for every sector because every service that you could offer has a different level of background information and literature. available to it. This project is a perfect example of having all that great work that the ITSC group had done through their work with CAPHC, that document that they brought to the November symposium. It was such a great starting point for us to have had a group of experts already sat down and take a look at what are the gaps and what needs to be addressed to really meet the needs of these clients in these risk areas. So that's a perfect example of things that we would incorporate into the literature review. Our standards working groups, as I mentioned, they are experts in the field, and we try to design a group so we get a good cross-section of people from across Canada, different types of organizations. We want urban and rural organizations, large and small. Depending on the service, we want private and public. We want to involve our key partners. We want to have Accreditation Canada surveyors run the table. And it really is a bit of an art trying to get a good cross-section of people. The working group that we have comprised for medical transport, it's quite a large working group, which is a great thing, and we were able to engage a lot of the reps who have been working with CAPHC over the years on that work as well, which has been really good. That being said, there are a number of experts that we're not able to tap into through a working group. And we try and tap into as many of those through our national consultation. So once we have a pretty solid, close to final draft of a set of standards, we want to evaluate it. We do this through national consultation. We send out, it's a web-based tool, we send out to all of our client organizations, stakeholders, ministries of health, all of our surveyors, and we ask, if you get it in your inbox, we ask you to fan it out as broadly as you can, so to give as many people as possible to provide input on a new set of standards, so we know, does this apply? Does this apply in all settings? Is there something we're missing? Is there a specific service area that's maybe not a good fit? We want to hear all that so we can make as many changes and enhancements as possible before we release it into the program. And then when we have new requirements, new standards in the program, we do an on-site evaluation. So we'll actually go out to an organization and do a bit of a mock survey. We give them a few weeks to work with the standards and do a self-assessment, and then we go with a very small survey team and usually a staff facilitator. I've been lucky enough to go on a few of these in my time here at Accreditation Canada, and it's amazing. It's amazingly valuable for developing a product, as well as I've always heard from organizations that it's very valuable to be a part of as well, because they get to have a really hands-on test run of the standards. It doesn't affect their accreditation decision, and they get to provide their feedback that's really specific to their organizations in a really real way. So it's always a really interesting thing to be a part of and to witness. And then after we've done an evaluation, we use all that feedback that we hear from across the country in our working group to make any final changes. We do present final changes to our standards working group to make sure that what we're hearing is consistent and that they support any changes that we've made. And then our standards are released into our program. We have one release a year here at Accreditation Canada. We release new products in January, and we give organizations 1 year to prepare with those standards and come up to speed before they're active in an on-site. Right. So, meaning organizations can self-assess and work with that and develop QI plans and really have those in place before our surveyors come. So, as much as that, it is that summary of how we do things is a little bit general, that is the process that's been followed for the medical transport standards. So looking back at the emergency medical services standards which is what exists in the Cumentum program right now. They've been in the Cumentum program from 2009, and as I mentioned, that update cycle being an ongoing process and really depending on what's going on in the field, they were updated in January of 2011 because we received feedback that we needed to add content on dispatch services and really how dispatch works with the rest of the service and whether it's integrated or not. So that was a major change that was made in 2011. And then again in January 2013, we made some more structural changes to the standards. They used to be needs to have all of our leadership content embedded into those standards. And what we did is we removed that content. So EMS organizations do use the leadership standards as well as emergency medical services. And as well, we added the required organizational practices into the program as well during that time. So there's the visual on the bottom of the screen there shows you the ROPs that were added to the EMS standards in that 2013 update. And as Kate mentioned, we had that great November symposium with CAPHC where we worked with the ITSC working group and really kind of got down to the nitty-gritty that day and went through what their recommendations were. They've used the emergency medical services standards as a framework to inform those recommendations. And really what came out of that from an Accreditation Canada side is that there were gaps in the program, which is not something that we like. But it's also great because it informs a new project in this partnership. So really, as Kate mentioned, the emergency medical services standards, although they weren't designed to be exclusive of air transport, they're really looking at ground transport. They really read like that, and there needed to be some additions to those standards and some changes if we were to include air transport in there as well. And as well, there was also some gaps identified around critical care transports and some of the partnerships that need to be in place to ensure that organizations are doing interfacility transports in a safe way and really supporting teams that are doing this. So Accreditation Canada, we made a decision to revise the emergency medical standards one more time and established a standards working group to provide guidance on that. The working group was formed with great input from CAPHC, and as I mentioned, some of those, a number of those members of the November symposium are representative on that working group. Right now, the structure of the standards, the organizations, the way we're designing medical transport with the revision is that organizations will work with the leadership and governance standards and then use medical transport standards to inform all of the services. While we're looking at new content to add to the program, the idea is covered a little bit in this slide, that we need to be cognizant that organizations across the country vary greatly. There's a great variety of services, of types of vehicles that are used, methods of transportation, and the teams that are offering these services. And we really need to appreciate the diversity and differences between air and ground transport, right? And as well that those differences between what types of teams are providing care, whether they're doing scene response or interfacility transport, and making sure that all complexities of care are covered and all those issues of quality and safety are crossed off there. So right now we're at a bit middle stage for a standards development. So our standards working group has had, we've had 2 face-to-face meetings in Ottawa, one in May and one just in August, where we've gotten a lot of good feedback about how we're building this program. So we want to make it as inclusive as possible to all types of transport, but still try and maintain the specificity so it's meaningful and really covering off those key areas of quality and safety. Right now, where we are in next steps, we're working internally on getting a draft to our working group this fall. Should be actually in the next couple of weeks. So they can really have another really good look based on the feedback from their last 2 meetings. And we're looking at moving into the national consultation phase in the spring of 2015. So I'm hoping that everyone on this webinar has this land in their inbox and sends that out to any of their colleagues. And as well, we're looking to pilot test specifically the air services and in an air context, and also in the spring of 2015 for these standards to be released in January 2016. So what that means in terms of what I was speaking about earlier, if we release standards in January 2016, they become active in organizations' on-site survey in January 2017. And then also just to mention that primer program, while primer does have EMS-specific content right now, we would want to revise that as well and make sure that we're covering off both air and ground and interfacility transport for any new organizations that are coming onto the program. So that is where we are sitting right now with this project. And so that is it for me. And I guess if there's any questions, I'm happy to take them.
I think
All right, thank you, Stephanie and Alan and Kate. We did have a few questions came in. This first question came in right early on in the beginning during your section, Alan, and it's from Mike, and he's asking, given that there are no Canadian standards for transport in pediatrics, were there any kind of similar standards for the adult population in that regard? And I think he's specifically talking about interfacility critical care transport.
So if the question is in regards to Canadian standards, the answer would be no. There are, for interfacility from the United States, there are standards which I'll probably turf over to Kate to speak a little bit to, that exist for, although originally they were drafted for air, they are air and ground. Kate, do you want to speak to them a little bit?
Sure. I think you're referring to the CANE standards, which is the Commission on Air Medical Transport Systems. But the question sounded a bit like, are there the adult equivalent of what we've been developing for neopeds and OBS and for Canada? And the answer is no. We certainly talked about that at our working groups in Ottawa, particularly in August, because obviously CAPHC and myself was there and others off our committee were very strong that we already had the competencies described for instance, in that practitioner profile. We are not aware of any equivalent document that would exist for adults, if that was what the question was.
Yeah, I believe that's what the question was, yeah. And I think it came in when we were talking about identifying the gap in the pediatric sense. I think the question was motivated by, was there an adult model that we could have built from? But I think the answer to that is there was no adult model that we could have started with to build from at that time.
Right.
The next question that came in was from Carolyn, and she's saying that most services going through the Accreditation Canada survey process address a standard related to feedback from patients. And she goes on to ask, will the transport standards include feedback from patients and families who have utilized a transport service?
Yep, that is a part of the program that applies also to emergency medical services and medical transport, recognizing that it might look a little bit different in an EMS setting, but yeah, it is definitely still part of the program.
Right, and that's all the questions that we've had come in so far. So if anyone else does have any questions, please feel free to start. Get those fingers flying on the keyboard. We'll give everyone a few minutes to think of something.
And we're just going to finish off with a few slides there that Alan's going to go through.
And we did just have one from Mike that's asking, what service will be used for the pilot accreditation process in the spring of 2015?
It'll be the medical transport standards that are being developed right now would be used that's what we are pilot testing. We don't know what organizations will be taking part in that yet. We've yet to ask organizations. That's something we'll be looking at doing probably later this fall or early in the new year, asking what organizations might be interested in pilot testing the standards for us. But when we select pilot sites, we like to get a good like to get some diversity across the country. A little east, west, central look, urban, rural, to really make sure that we're seeing how the standards work in a variety of different ways. If your organization would be interested, happy to be contacted about that.
All right. And the last question that we've got for now, before we move on to Alan, was from Scott. And he asked, did the authors consider in the practitioner standards, I think it means the practitioner profile, setting both a minimum standard and a standard of excellence to guide programs in developing towards the best they can be?
Certainly when we looked at the practitioner profile, although the descriptions of the competencies may look somewhat generic when you're reading through them, we were talking about performing those competencies at an advanced level of knowledge and skill. So you will see that it actually builds on general competencies throughout the document. It'll mention things like that, but we are not looking at a minimum in the sense of these are advanced care that are actually working in this environment?
Kate, it's Elaine, and maybe just to add a little bit to that, I think it's important, specifically at this point with the practitioner profile that you shared with us this morning, that there is an opportunity for folks to select depending on the niche or patient population that their individual organization may be focused on. So, although that I wouldn't frame that as a program of excellence, I do think there was a little bit of that considered in the development of that document.
I would agree.
Mm-hmm.
All right, we did have another comment from Scott related to the other accreditation programs, and he says, as far as he knows, there were 3 CAMES accredited programs in Canada. So, and Laurel put in a question asking, is STARS transport involved in this or independent of this? She has not heard it mentioned yet, and STARS being located in Alberta. Alan, maybe we can ask you about that.
So clearly, STARS has a very well-organized transport system for adults and children. Now, I guess in terms of there have been points of contact with STARS over the years, sharing ideas and getting some input. When it comes to actually sitting at the table, coordinated by Accreditation Canada, I'll throw that back to Stephanie and Kate as to whether or not they're there right now. They'd know better than I.
We do. We have representation from STARS sitting on our working group.
All right, that's great then. I think that's that's all we have for questions right now. So let's go on with the rest of the presentation. Over to you, Alan.
So Stephanie's already really shown hopefully what the trajectory is for us over the next 2 years, or actually over the next 3 years, towards ultimately having a standards program that is going to hold all of us accountable for how infants, children, and high-risk moms are transported. I think the challenge that we end up having here is that this is more than just, at least going back to what we heard from the people in Edmonton in 2008, this is more than just having standards, right? Standards are very, very important. I think if anything, it ends up allowing for to make sure that the system itself is actually doing what it should be doing. But I think it does end up being more than that, and I think some of the ideas that have come out of the Interfacility Transport Group has been whether or not we can actually start working with our CAPHC colleagues that are already involved in transport or are becoming involved in transport to actually, at the ground level, start sharing experiences, sharing ideas, working collaboratively to try and for all of us to be able to provide excellence. And so, some of the ideas that have been floated, and these are ideas that are very much up for negotiation. End up including looking at clinical practice guidelines, and initially the plan had been we'd wondered whether or not we were going to have to create clinical practice guidelines. When we actually went and dug around through our respective organizations and partners across the country, we found actually a wealth of clinical practice guidelines especially for neonatal and pediatric transport, which has really left us, thinking that we're actually kind of starving in the midst of plenty. There already are some wonderful CPGs that we all can end up learning from. This is not a matter of, in the same way that we said right at the beginning, there's not going to be a single transport program or team that is going to be relevant for every system across the country. The same thing applies to clinical practice guidelines. What is going to work for us when it comes to resuscitating and transporting a high-risk neonate in an urban center is going to have some common features, but still will be somewhat different than what we have to do to ensure the safe and effective transport of that same neonate if that neonate was actually in a rural center, which was going to entail a significant transport. So So these clinical practice guidelines that we have from many of our colleagues across the country, we end up, what we're thinking on doing is actually looking at opportunities to be able to share those clinical practice guidelines, and whether or not what we end up doing is, this is more than just putting them on a website. Our thoughts were actually using them to facilitate discussion, potentially through a webinar format with many of our colleagues and interested CAPHC parties across the country to be able to look at, we've got these ideas, we've got these CPGs. Can we make them better for those people that are actually working in different parts of the country? What are the kind of ways that we can help make a CPG more relevant to what their needs are in the community that they're transporting infants and children in? And finally, I think the other option of knowledge translation that we've been looking at is whether or not, going back to some of the original comments that were made in Edmonton of, wouldn't it be nice to actually be able to share the educational models and the training models that exist in some of the bigger pediatric teams in Canada, to share those with others, both advanced teams as well as teams that are just starting. There really shouldn't be a need to reinvent the wheel. We should be able to learn from each other. So it's more than just, as I said, more than just clinical practice guidelines. It's what's when it comes to the educational infrastructure that needs to exist in every team, what can I end up learning from what a team has already put in place in Eastern Canada, and what do I need to do to actually establish a standard of excellence or make even more excellent the transport team that work in my community. So those are just ideas that we've thought of to this point in time, but I think clearly, it's what we're looking at is trying to get this a lot more ideas from the CAPHC community, and hopefully we may have some ideas from people even on the line right now if they're willing to share those with us. I think Ken is going to be a wonderful way of housing a lot of these CPGs, presentations, discussions. Once again, hopefully, literally a kind of a transport go-to housing center, so we can all work with common resources. But I think, I'd leave this, and I think, Kate and I would like to leave this with the people on this call right now, to actually ask them, what do they see as allowing them to move forward when it comes to interfacility transport of neonates, children, and high-risk moms, especially in specific when it comes to the knowledge translation piece. Are there other aspects that we should consider, other ideas that listeners might have right now, as to how we can actually share our collective knowledge and actually move forward obviously our agenda. So I'd like, hopefully, that we've got some people that, even as we speak, I hope some people are maybe emailing in some comments. And we'd be happy to answer any questions or respond to any comments that people might have in general as well.
All right, thank you, Alan. So as Alan suggested, if you can either email any suggestions or comments to us is great, or if you want to put something in the question box now for us to discuss today, it would be great as well. We've got about 10 minutes left. We did have a comment come in from Adam, and I'm going to read it, Adam, but I'm not sure, just with people rushing to type something in and sort of using short forms of stuff, I'm not sure I understand the question, so I'm not sure our speakers will understand the question, but I'm going to ask it anyways, and if we need some clarification, you can feel free to type something in the box. But Adam is saying, first of all, he says he's new to this area, so he apologizes, but he's asking, in developing these standards, these transport standards, is there a cost/resource component? For example, transport versus developing expertise in the healthcare facility. So, Kate, Alan, Stephanie, I'm not sure if that question makes sense to you or not, but...
Who wants to go first?
And my confusion was around what specifically he means by cost resource component. So
maybe I'll just speak to a couple of general comments. When it comes to the work that's been done by the group, clearly, I think that there's been a lot of work and goodwill done through CAPHC and actually helping this process move forward. And there is no big budget that's allowed this process to evolve to this point in time. Although, as I said, there's a huge amount of infrastructure and that CAPHC has provided for us. But I guess if the question ends up being not the process of actually creating this the standards right now, but ultimately moving beyond that to standards once created by CAPHC. Stephanie, do you want to speak to that? Is there a cost issue that goes along with that?
Yeah, I'm not quite sure. Sorry, I'm just not quite sure how to address that. I mean, there's a development cost that we deal with internally, but in terms of organizations implementing our standards, I mean, it's really, I can see where sometimes to meet standards organizations would incur some cost. If there's elements of their program that are missing, but Accreditation Canada is expected to see that on site. That being said, we try to keep things as at least resource intensive as possible when we're designing things to make sure organizations can work within their current structures and really just improve current strategies and the goal is usually that you're looking at and reviewing processes to make them more efficient and more client-centered and safe to avoid costs, right? So less incidents, less costs, less safety risks, less costs. So I'm not quite sure if I'm answering the question, but that's I guess what I can provide from Accreditation Canada's perspective.
I guess speaking as a past administrator, certainly once standards become visible and you know what you're striving for, if there are gaps in your current system, sometimes that does result in resources needing to be invested to reach for that. I think Stephanie's point is that ultimately I always found that investment returned itself in terms of the quality and the issues that went away because you were able to meet the standards. So yes, sometimes there is a cost, associated with reaching for those standards.
Well, Adam did put in a bit of a clarification here. He's clarifying by saying he's giving an example. He said if the overall cost for a specific hospital to transport patients is, say, $100,000 per year, has it been considered that developing the expertise within that hospital might be the more cost-effective route so that they do not need to actually transport the patient at all?
Alan, that might come back to your first slides where we were talking about regionalized care.
Yeah, I think it's a fair question, and I think the reality that we have in especially in Canada is that ultimately to have true excellence in care, what you have to have is you have to have it's a matter of having the adequate patient exposure, the physicians, the nurses, the infrastructure, and ultimately what that comes down to is that in the absence of regionalization, what ends up happening is that the standard of care, if offered in non-regionalized centers, and this is what we see in a lot of parts of the world still, is inferior to if you've got regionalized care provided. Regionalization of critical care services for neonates and children leads to improved patient outcomes. So I think if there may be. I'm not sure how many large centers exist right now that are looking at See, the issue is not just a matter of transport as in transporting patients to another center. Often that transport, that infrastructure and that transport program, it's a matter of having that in place to be able to transport patients to your center, right? So it's ultimately what it comes down to is that there are, you need to have, there is a limited number of centers in a regionalized healthcare model to provide excellence. All of those centers, for the most part, need to have a well-structured transport model. But ultimately, it comes down to you need to have, you need to have enough patients and a big enough center to be able to support that kind of a model.
All right, thank you. So the next question is coming in from Scott, and he's asking, would large established programs be willing to partner with small or rural programs for staff to gain hands-on experience so the small program gains hands-on experience with a large volume program rather than just the didactic knowledge sharing?
Well, I think that's a tremendously good suggestion, and just having worked the way we have over the last 6 years with large and small programs, and some of the inquiries that have been coming into us, there certainly seems to be a willingness out there to consider. I don't think, and I'm not aware if that has been asked from program to program, but certainly that's something we'll bring back to our hearing committee as well.
Absolutely.
I think just to build on that, there's a couple of concrete examples that I can give that show how I think there is the willingness in the system to see something like that happen. First of all, even at the level of tertiary care to tertiary care institutions, this isn't just a matter of sharing between big transport team and little transport team. Here in Alberta, we've had challenges over the last 15 to 20 years in having, both in Edmonton and in Calgary, being able to build and sustain our programs in each of our centers at Alberta Children's and at Stollery. And there has actually been a lot of work intermittently over the years where we've actually worked collaboratively to try and share some of the load when it comes to teaching and other aspects of team building. I think the other point when it comes to tertiary care to smaller transport teams, one of the things that we've seen in Alberta, we've got I said right at the beginning that pediatric transport is a limited resource. We don't have one on every street corner. We can't send out a pediatric critical care team to move every sick child. And when you're talking about long distances, as we are, for instance, here in Western Canada, that means that we need to be able to, in some way, support the smaller transport teams. So these are EMS teams. And sometimes we may be talking critical care flight paramedics, but they're not pediatric critical care flight paramedics. How do we, as bigger teams, work with those smaller teams to be able to we're not trying to make them a pediatric critical care team, but to give them at least some of that experience, cognitive and technical skills, so that if they are going to have to move a child because a critical care team, peds critical care team isn't available, that they can actually do it. And that's actually, it happens sporadically in Alberta right now. I'd like to see it happen more, more systematically. I know it does happen better in other parts of the country, but I think it's not just that it makes sense. Well, it does. It's not just that it would be nice to do. It actually makes sense, and I think it would be good for patients if we actually move forward with something like that in a more systematic way.
Mm-hmm. Well, that does lead nicely into the next question, and which is the last question, and we are out of time, so I think this is the last question that we'll take. But it's from Viva, and she's asking a question very much along the lines of what you were just talking about, Alan. And she's asking, will the work you are undertaking provide clarity around the requirements for nurse or physician escort from the sending facility to accommodate the transfer of a newborn from a rural, remote level 1 facility to a level 2 site where the ground transport is available, but the ITT is not? So, for example, identification of parameters where the ground EHS crew scope of practice ends and that of the hospital staff is required.
Well,
Kate, do you want to speak to that?
I will. I think that that is one of the things that we wanted to address was that if you are in the business of transporting this population, here is the minimum set of competencies that you need to be able to accomplish if you're going to transport that, whether that's a ground system or, as Alan has said before, and we know that's the reality, is who is the nurse and the RT perhaps who are available to transport this patient. Well, we need to be able to turn to something that says this is the kind of skills and knowledge they need to have to do that. So I think by the work that we've been doing, we're making visible what is the minimum that you do need to do to be in this business.
Mm-hmm. Mm-hmm.
I think the one comment I'd add to that as well is that we have many very hardworking healthcare professionals in smaller communities that are often left having to move patients themselves, where they are, they're throwing together equipment and personnel at the last moment because there is no easily accessible resource for neonatal, pediatric, or high-risk maternal transport. Hopefully what comes out of this is that actually, and this is where this comes back to the standards piece in Accreditation Canada, although none of us are looking at this as a stick process, if the healthcare organizations realize that in order for patients to be moved safely, there needs to be a system in place that does that, and that entails resources, and that maybe it's not the best use of community resources to actually be taking those people out of the smaller center to move that patient, and it's definitely many times not in the best interest of the patients to be moved by a referral hospital team. What do we need to do to be able to make sure that we have easy accessibility to an appropriately skilled and trained team in a timely fashion? So I think that's that's not unintended consequences. That are hopefully going to be the intended consequences of part of this, part of the accreditation process, is that it will end up holding the healthcare system, accountable for how patients end up being transported.
All right, thanks, Alan. And we are going to go over to Elaine Orbine for a final comment before we sign off.
Thanks, Doug. It is a quick comment, but I listening to the journey that our two co-chairs of this committee have provided today has been outstanding. So first of all, to Kate and Alan, thank you for your leadership for so many years and your continued support in this very important work. Partnerships, and I think today's webinar has really been an outstanding example of the strength and what a partnership can enable. Our partnership with Accreditation Canada has bared many fruit, and I think that our interfacility transport story is another really important example. And Stephanie, I really want to thank you and all of our colleagues at Accreditation Canada for your continued collaboration and leadership in this important work. It really is bringing two national bodies together. I'll refer to CAPHC's community as bringing the content expertise to this particular, I'll refer to it as a subject. And then Accreditation Canada brings the methodology expertise in how to develop and implement a standard so it is effective, so the implementation is effective. That is a very, very strong partnership. And lastly, if I can speak to everyone who has joined us on the call this morning and ask you to share the journey and the information, the various reference documents that are available to you, to share this with your respective communities. Let folks know that this is ongoing that everyone is welcome to become a part of it, whether it's accessing the resources and or bringing perhaps your voice on behalf of your community to this work. Come and join us as we move forward in the knowledge translation and education program that Alan described, because your voice means a tremendous amount to CAPHC and the work that we're doing. So I'm just going to turn things back to Doug, but really want to thank everyone for today's webinar.
All right, well, I will echo Elaine's thanks to our presenters, Dr. Alan McCann, Kate Mann, and Stephanie from Accreditation Canada. I don't have Stephanie's last name in front of me, but I was hoping that Sam would scroll the screen up and give me a tip there. But
it's Stephanie Carpenter.
Stephanie Carpenter, of course, I knew that. So thanks to all three of you for a great presentation. I mean, as always, you can tell by the questions and the discussion and the engagement of the audience that there's definitely interest in this topic. So thanks again to everyone, including our audience, for coming today. We do our webinars usually every Wednesday at 11 a.m. Eastern Time. As I mentioned at the beginning of the session, we are heading into our conference season. So our conference is on October 19th to the 21st. So we are taking a bit of a hiatus in the coming weeks from our webinars, but you can always go to caphc.org and the CAPHC Presents page where you can see a calendar of upcoming events, and you can always check the Knowledge Exchange Network at any time for upcoming webinars as well as any of the posted recordings. So be sure to check all of those resources to keep yourself informed of our activities, and hopefully we will see you on the next webinar. Thanks everyone for coming. We'll see you the next time. Bye.